to focus a significant amount of time on biometry, which would include the IOL formula calculations, IOL calculation in special situations. Then we proceed to other necessary ocular investigations and their recent advances. And then we should have some time for discussion in, if any. Next slide, sir.
Yeah.
Okay, so there is absolutely no substitute for a detailed history and a thorough slit lamp examination. All of us here have mastered the art of doing a good preoperative history, but a few important pointers that must be asked before you start examining the patient on the slit lamp. A few leading questions such as history of any prior ocular surgeries or any prior ocular procedures that the patient may have undergone, or history of any ocular trauma. Occupation in today's generation, today's era of premium IOLs becomes very, very important, because that is what is going to help us determine the visual needs of the patient, the working distance of a patient, and hence we can make a tailor-made approach for the patient. So now, thus a good slit lamp examination is the cornerstone of a successful cataract surgery. Why is that so? Because number one, it is going to help us rule out any other ocular comorbidities. Number two, it is going to help us make a risk stratification plan. Number three, it is going to help us preempt any intraoperative complications and help manage them better, be better prepared. So just to recapitulate in brief, a few findings that we're going to look for, spend a few extra minutes looking for, any corneal scars, any corneal opacities which may interfere with our intraoperative view, prior LASIK cuts, prior LASIK flap edges which may be seen on slit lamp examination. Corneal guttate is a very, very important finding that must not be missed. Certain fine old KPs which also can be easily missed if you don't look for them. The size of the pupil is very, very important. Whether there's presence of any pseudo-exfoliation, any iris atrophy patches, knowing the grade of the lens, whether you're dealing with a polar cataract, whether you're dealing with a posterior subcapsular cataract, whether it's a Morganian cataract, is going to help us manage the situation appropriately. And most certainly, there cannot be enough emphasis on a good detailed fundus examination, especially examining the retinal periphery with an indirect ophthalmoscope. Next slide, sir. So all in all, a thorough preoperative clinical examination is going to help us improve our surgical planning, which in turn is going to help us ease our intraoperative management and give us good post-operative outcomes. Next slide, sir. So now that we've decided that the patient needs to undergo a cataract surgery, what are the ocular investigations that we are going to do? So coming to biometry, which is the prime investigation of importance, an accurate, precise IOL power calculation is the most important determinant of a functionally improved, technically precise cataract surgery. So as postgraduates, we're used to the conventional biometry method, where you measure the keratometry using the manual keratometers, and the actual length is either measured using a contact method or an immersion method. Now, the contact method has a small fallacy that the corneal compression may sometimes predict and give us a falsely short axial length. So to counteract that, immersion A-scan method is a better advised approach for the ultrasound technique. Now, it is also important to note that a 1 diopter difference in your keratometry readings is going to land up with an almost 1 diopter error in the IOL power calculation, which is a 1:1 ratio. And a 1 millimeter falsely predicted axial length will give us a surprise of almost 2.5 diopters in our final calculation. So, in brief, since this is what we do at postgraduate level, we should know what is a good A-scan graph and what we're looking at when you deal with it. So you will technically see 5 high amplitude, sharply rising spikes rising from the cornea, anterior lens capsule, posterior lens capsule, retina and sclera, respectively. What is important to also notice, there should not be any echoes from the vitreous cavity. So this here, which is being shown on the screen currently, is the graph of a contact method, where the probe and the cornea are represented as a single spike. However, when we go ahead, this is the scan of an immersion A scan, where the probe and the cornea are shown as two separate spikes because they're no longer in contact with each other. Next slide, sir. So gain is a parameter that we should all be aware of, because where is that going to be practically used? So in cases of denser cataracts, when you don't achieve adequate height of echoes, you may want to increase the gain. And in cases of eyes where you, silicon filled eyes, where there are unnecessary artifacts which are seen, the gain may need to be decreased. Now, coming to the modern current approach to biometry, which is the optical biometers. So optical biometers are broadly classified into three types: the partial coherence interferometry based ones, the optical low coherence reflectometry based ones. The examples of each being the Iron Master 500, which is the PCI-based optical biometer, the Lenstar or the Aladdin, which are the OCLR-based biometers, and the latest advancement being the swept-sourced OCT-based biometers, which is the IOL Master 700. Next slide, sir. So let us see why the IOL Master 700 is considered a gold standard. Now, what you can see on the screen here is that it provides us a full-length OCT image of the eye. It also gives us the feature of a fixation check, which helps us to monitor an optimal fixation of the patient. It also not only gives us the anterior keratometry, but also gives us the posterior corneal curvature, which in turn gives us a new parameter called the total keratometry. It is also incorporated with all the modern IOL power calculation formulas like the Barrett suite, the Higgy suite, the Barrett-Toric calculators and all. So let us see a small short video of how the scan is acquired on the IOL Master. So in less than around 40 seconds, the IOL Master is going to take precise, accurate measurements of both the eyes, where the OCT image of the entire eye is then shown. So this is the other eye being calculated. And then it gives us a final raw data image. So this is nearly around 40 seconds where you finish the biometry of both your eyes. Next slide, sir. So as we discussed about, this is a scan where you see and where the fixation is not optimal because you cannot see the foveal pit. The inferior scan shows a tilted lens, which is why you don't get accurate measurements. So this is a feature which is going to help us determine and ascertain an accurate calculation. So if you have an image which shows a tilted or a decentered lens, you want to repeat the scan and check the patient's fixation again. Next slide, sir. Next slide, sir. This is again an image of tilted IOL. So this is where it gives us the recent IOL formulas that are currently in use, right from the Barrett suite to the Higgy suite and the other formulas. Next slide, sir. You could go ahead, sir. Next slide. It also helps us determine certain, could you please go back to the previous slide, sir? It also helps us determine certain retinal pathologies like a macular hole or age-related macular degeneration, which is then going to warrant a macular OCT. Next slide, sir. So this is a brief overview of all the newer optical biometers which are available with their additional attractive features mentioned below. It's worthwhile knowing all the features available with the latest biometers. Next slide, sir. So all in all, why is an optical biometry superior to an ultrasound? Number one, because it is more precise, it is less error prone, it is faster, more comfortable for the patient. It eliminates the cumbersome IOL power calculation methods. It gives us the true axial length of the eye. That is, the axial length is measured from the tear film to the retinal pigment epithelium, in contrast to the ultrasound biometer, which measures the axial length from the cornea to the ILM. So this is something which is more helpful in eyes with a posterior staphyloma. Next slide, sir. So now that we've acquired our readings, the next big question is what IOL formulas to choose. So there, in the older classification for IOL formulas was based on the historical refraction-based method, which is now obsolete. Then you have the regression-based formulas, which are the SRK1 and SRK2. And then you have the Virgin's formula. So most of the modern day IOL formulas are based on the Virgin formulas, which use the Gaussian optics or the Fodor equation. The newer methods are the ray tracing, which is the Ostlin formula, and the artificial intelligence, which is the Hill radius basis formula, Hill RBF formula. Let us have a closer look at all of these ahead. So what is the one determinant that all of these IOL formulas try to predict? That is an accurate, effective lens position. So all these modern fourth generation formulas try and give you a precise biometry by determining one variable, that is the effective lens position. Where is the lens going to be positioned post-operatively? So depending upon the number of variables that they use, the Virgin's formulas can be classified as 2 variable formulas, 3 variables, 5 variable, which is the Barrett Universal 2, and 7 variables like the Holladay 2. This is again an overview of the classification of the IOL formulas. So what conventional methods have taught us, what we used to previously do is for shorter axial lengths, Hofer Q is the preferred formula. For normal axial lengths, most of the formulas worked well. A Holladay 1 or an SRKT was chosen. And for longer eyes, the SRK2 was considered important. But however, in today's era, next slide, sir, what the modern IOL formulas are, the Barrett Universal 2. Now, Barrett Universal 2 is a formula which can be used unmodified in eyes of all axial lengths for all IOL designs, hence the term universal. It uses 5 variables, that is the axial length, the keratometry, the anterior chamber depth, the lens thickness, and the horizontal white-to-white corneal diameter to calculate an accurate effective lens position. It is known to predict IOL formulas accurately in long and short axial lengths. Coming to the other formula, which is the artificial intelligence-based formula, which is the Hill RBF formula. Now, this is something which is incorporated in the LensStar, and it is also freely available online. Now, taking things a step ahead is the ray tracing formula, which is the Ostlin. So Ostlin basically uses a principle of a modified C constant, which helps us predict the effective lens position more precisely, as it takes into consideration the characteristics of the crystalline lens and the dimensions of the anterior chamber. Next slide. So in a study by Robert et al., the Barrett Universal 2 formula has proven to have the lowest risk of refractive surprises compared to the other intraocular lens formula, lens power calculations. And Hill RBF is equivalent to the Barrett Universal 2, especially in short and long eyes. Next slide, sir. So now coming to another challenging situation, that is calculation of IOL power in post-corneal refractive surgery patients. So the issue that happens here is that the refractive surgery modifies only the anterior corneal curvature. The posterior corneal curvature is left unchanged. So it basically alters the normal anterior posterior curvature ratio. So most standard keratometers are going to fail to give you an accurate measurement of the corneal power. And to add to that, all our newer IOL formulas take into consideration the keratometry to give you an effective ELP. So to counteract that, next slide, sir. So these were the older formulas that we were aware of: the double K formula, Maskit, clinical history method, the Shamas formula, the Wong-Kok nomogram, which was added. Next slide. So the current IOL formulas that are used are the Hage's L formula and the Barrett True K formula, which are available on the IOL master, and they're known to give you near accurate results in post-refractive surgery eyes, which are also available freely on the ASCRS website. Next slide, sir. Now, the next challenging situation is calculation of biometry in silicon-filled eyes. So what can be done for the traditional ultrasound method is that you apply a conversion factor of 0.7 to the measured axial length to correct for the apparent increase in the apparent increase in the axial length, which is induced by silicon oil. However, to make things less cumbersome, the ideal method would be to measure it using an optical biometer. Next slide, sir. So now, having discussed biometry, let's move to the next important investigation, which is the macular OCT. Next slide. So a macular OCT ideally should be mandatory for all patients undergoing a cataract surgery. Why is that so? Because there is a study which states that around 10 to 17% of cataract patients have macular findings which are not seen on clinical examination. Epiretinal membrane being the most commonly missed one. So what we're trying to look for on the macular OCT is any vitromacular interface issues like a vitromacular traction, mild amount of subretinal fluid, any irregularities from the RPE, lamellar holes, macular telangiectasias, because all of these are going to help us rule in or rule out certain premium IOLs. Next slide, sir. So next slide, please. So in today's era of a refractive cornea cataract surgery, the array of ocular investigations have to be increased further. So moving on to the next very important investigation, which is the corneal topography. Now, why is the corneal topography important? Because number one, it is going to help us identify any irregular corneas, irregular astigmatism. Early cases of corneal ectasia, such as early cases of corneal ectasias. Can you go back, sir? Early cases of corneal ectasia, such as keratoconus, PMCD, and it becomes very, very important, especially in cases of post-refractive surgery, because it will help you identify whether the patient underwent a myopic treatment or a hyperopic ablation, also to determine whether the optical zone is centered or decentered, and certain placido-based topographers will also give you a raw image of the ocular surface. So if you have distorted Myers, you're dealing with a dry eye patient, and that needs to be treated first. Next slide, sir. Now, over the last few years, ocular surface examination is something that has gained increasing importance. Now, a study which is known as the FACO study estimated that the prevalence of dry eye in cataract surgery patients is highly underestimated. So why is that important? Because number one, the two most important reasons for an unhappy patient after a perfect cataract surgery is either a refractive surprise or a poor ocular surface. So the ocular surface is going to give you a lot of quality of vision issues, is going to interfere with an accurate biometry measurement. So what are the tests that we could do prior to the surgery is a tear breakup time, the Schirmer's test, a fluorescein staining, and an ocular surface disease index score, which could, a questionnaire which could be handed over to the patient. Next slide, sir. Now, a USG scan is not mandatory in all cases, but however, in situations where you cannot see the posterior segment in dense cataracts, you want to rule out a retinal detachment or a vitreous hemorrhage or an intraocular foreign body, that is when you do a USG scan. A specular microscopy, again, when you suspect clinically a poor endothelium, that's when you want to do a specular microscopy. Especially when the cell count is less than 1,000 cells, the risk for corneal decompensation increases. Next slide, sir. So aberrometry is something that has gained increased importance, especially in premium IOLs. Now, this is not an investigation that we would routinely do for everybody, but yes, in premium IOLs, it is very important because it helps an aberrometer is going to give you a separate division of higher order aberrations, which will be divided into the aberrations arising from the cornea, the higher order aberrations arising from the lens, and the total higher order aberrations. So in situations when you have a patient who presents with a 20/20 vision but complains about visual symptoms that may be related to a cataract, so when you subject this patient to an aberrometry, you may have an increased OSI signal. It may show increased internal aberrations, which means that this patient may not have a clinically significant cataract, but doing an early cataract surgery is going to help him achieve a better quality of vision. This is also very important in post-refractive surgery patients. Let us see why in the next slide. So this is what the eye tracy is going to look like. It gives you a breakup of the higher order aberrations into the internal aberrations, the corneal aberrations, and the total aberrations. Next slide, sir. This is a patient where you see increased amount of aberrations. Now, these aberrations are not coming from the lens. However, all these aberrations are coming from the cornea. If you have a look at the topography here, it is a completely irregular cornea. So this is not a ideal candidate for a premium IOL, because he's going to land up with a lot of photopic symptoms and a poor quality of vision if a premium IOL is implanted here. So a short discussion about intraoperative aberrometry, or the Optiwave refractive analysis, ORA. Now, this is a system which helps us measure the phakic, aphakic, and pseudophakic refraction at the time of cataract surgery. So it also helps you accurately determine IOL power calculations in eyes with prior LASIK or PRK. It also gives you a guide to determining the accurate toric IOL alignments and hence managing residual astigmatism. Next slide, sir. So after having discussed the exhaustive ophthalmic investigations, ocular investigations, a systemic history ruling out diabetes, hypertension, ischemic diseases, asthma, are also very important. And an informed consent cannot be emphasized upon more. So to summarize, a systemic comprehensive examination is going to consist of, next slide, sir, identifying ocular comorbidities, having a risk stratification system, a perfect precise biometry, appropriate incorporation of all the newer technologies available, which is going to in turn help us achieve a happy 20/20 patient. And patient counseling regarding realistic expectations is very, very, very important. Thank you everyone for your patient listening. We could have certain discussions about things now.
Thank you, Dr. Nupur ma'am. That was really a good and concise talk covering all the aspects of our cataract surgery workup, which is very important because this is generally we are doing for all the PGs who are newly joining into ophthalmology this year. So
Yes,
I request all the participants that they can either unmute themselves and ask the questions, or they can type in the chat box, whichever is comfortable for them, and we can have a discussion on that. Meanwhile, I would like to ask you a question that you showed us this. Do you have any personal experience using the Optiwave refractive analysis?
No, sir. I do not have any personal experience using the ORA, but there have been a lot of studies which have compared the ORA to the current fourth generation calculator. So what ideally is done is that a biometry using the fourth generation formulas is done pre-operatively, and then they're compared intraoperatively, which almost gives you the same result. See, the ORA is something which is going to give you accurate results when you're planning a toric IOL for proper placement, or especially in cases of post prior LASIK surgery when you can get an aphakic correction of the eye.
Okay. And one more question, about the post LASIK IOL calculation. Uh, do you use ASCRS online formula, or you generally rely on your Barrett's only?
So I generally rely on the IOL Master 700, which has the Barrett Truque formula instilled. So that can also be compared using the ASCRS online calculator. So basically, I rely for post LASIK eyes on the Haigis formula, which is incorporated in the IOL Master 700.
Okay. And there is one more question coming from Dr. Mohit. Which is your choice of machine for IOL calculation? I think you have cleared it here already.
Well, my current choice of machine has to be the IOL Master 700 because at the current moment it is the gold standard which gives you all your latest IOL calculations. It helps you calculate even in denser eyes and post refractive eyes. So yes, that would be my current choice.
But again, Nupur ma'am, in cases of posterior polar cataract or even dense mat-cat, do you get readings on your IL Master
Yeah,
700?
yes. So yes, like what you correctly pointed. So here the immersion method comes to a rescue because even with the Swepsos OCD based device, in certain polar cataracts, dense posterior polar cataracts, in mature cataracts, the IL Master 700 may not give you an axial length measurement. So then you have to eventually go back to the immersion method and get your axial length from there. So it becomes very imperative at your PG levels to master immersion biometry technique. Because however, in advanced cases, the optical biometers may sometimes fail you to give you an accurate axial length measurement.
Okay, fine. And then one more question that I wanted to ask. You have pointed out the importance of corneal topography in pre-operative cataract surgery workup.
Yes, sir.
But do you advise in all
Yes, sir.
the cases of pre-operative workup, or is there any threshold, like you find certain difference in keratosis?
No. Mm, no. So when you're planning a toric, now all these investigations for a routine cataract surgery patient may sometimes become very expensive and may not be feasible for everyone. So topography is something that you would ideally reserve for when you're planning a toric IOL because you want to check whether the astigmatism is regular, irregular. So in case of an irregular astigmatism, you may not want to put a toric IOL because it may not give you accurate results. In refractive surgery is very important because you want to rule out whether the ablation zone is decentered, whether it is well centered, whether it was a myopic ablation or a hyperopic ablation. So topography precisely is going to be helpful in when you're planning toric IOLs and in post-refractive surgery cases.
Okay. So there's one question coming from Dr. Kumar, like how you perform a long duration mydriasis patient in operation for the cataract surgery.
So, so ideally, sir, usually we do not put any midriatic in our VSS. So, in cases when you have a small pupil, what we ideally like to do is use intraoperative phenocane. So, phenocane helps you dilate the pupil, and even if your pupils become shorter, it's going to then give you a decent exposure of the lens. So use of an intraoperative phenocane is something that I would recommend.
Okay, fine. And then there is one more question coming. Did you observe any complication post cataract surgery in COVID-19? Maybe in the COVID-19 patient, they wanted to ask for any complication related to the systemic COVID-19 disease post-operatively. Ideally, I did not. Yeah.
Pertaining to
I think
cataract.
they want to know. Yeah,
No, so
intraoperative, post-intraoperative surgery. I think they want to know about it.
what happens with what we're seeing with COVID-19 these days is that a lot of them are coming with retinal vascular anomalies. So sometimes you may have patients who are presenting with BRVOs and other vasculopathies, which will have a macular edema. So this is what is going to hamper your postoperative visual outcome. So this is one thing which otherwise related to COVID and cataract surgery related complications aren't very haven't really have been come across yet. But yes, retinal vascular occlusions or any form of nerve palsy are something which is very commonly seen.
And in my experience, what I saw, not anything post cataract surgery, but we do get cases of superior ophthalmic vein thrombosis. Like I saw there are two cases of superior ophthalmic vein thrombosis along with the fungal orbital sinusitis. And in such cases, we had no option than to start patient on the antifungal and anticoagulants. And one of them did require exentration also. So, but not intraoperatively, actually, they presented like that. And though they were diabetics, they recovered from the COVID, but post-COVID, they developed this kind of thrombosis. So there is one more question coming. Do you prefer AC IOL or iris claw in Affinix? What is your IOL of choice?
Iris claw is my preferred method, sir.
Okay, iris claw. Fine. So anyone wants to ask anything, please free to ask. Meanwhile, we can continue the discussion, Dr. Nupur ma'am. So in this again, like you pointed out very aptly that FACO study showed that the ocular surface disorder is one of the main reason for the unhappy patients. So in such a scenario, like patient has a dry or rheumatoid arthritis, and you treated them, and even after treating for a longer while, your Sharma still remains 6 to 8, and sometimes they do develop a mature cataract early because they are on the steroids for the long term. So what do you
Steroids,
advise
long-term
in
steroids.
such cases? Like what are your preoperative precautions and what is surgical planning right from the incision to the
So,
postoperative drugs?
right. So, like you pointed, if it's a mature cataract, this has to be dealt with earlier because vision rehabilitation is very important. So now in such cases, maybe making a corneal section is more important because it's going to cause lesser ocular surface inflammation. Being, avoiding any form of unnecessary, a phacoemulsification is what would be my choice of surgery in such patients, and being very calculative about about your steps so that you don't waste unnecessary time and cause more unnecessary inflammation to the ocular structures. And yes, maybe you can, they're all already on systemic steroids. So maybe considering certain oral immunosuppression, a long-term immunosuppression form of other immunosuppressants, and continuing topical cyclosporin, topical steroids for a longer duration with topical lubricants.
So basically, minimum handling of the surface, avoiding any
Minimal handling.
viral, and immunomodulators do play a role in having a healthy ocular surface in such cases. It's always better to get your Sharmas
Exactly.
objectively above 8 to 10, but many times it does not happen. Then you have to rely on this thing, and you need to counsel the patient that the regular follow up and the chances of post-operative dryness might be there, but that's what their ocular surface is like. And again, this silicone oil filled about those surgeries, especially post vitrectomy eye, or many times nowadays what we face is a patient of ARMD. They have underwent many of the intravitreal injections, and we never know the lens touches happened or not happened because they do go to the multiple surgeons and they take injections. So in such cases, what do you counsel the patient, or have you faced any untoward surprise during your surgery or post-operative?
Now, in silicone filled, or especially people who undergone a vitrectomy, it is very important because sometimes during an intravitreal injection or during the surgical procedure, there may have been a lens touch. So, a chance of a posterior capsular rupture becomes very high. So, special precaution has to be taken in such cases because you need to be prepared for the adversity of a PCR. So, that has to be managed, that has to be kept in mind. Get post-operated, post-vitrectomized eyes are going to have a higher chance of a posterior capsule rupture.
And having your retina colleague standby always helps in such cases.
Yes, exactly.
And again, very important question for the pre-operative workup. Like many of the times, we do have a one-eyed cases, one-eyed patients. So, at the protocol in some of the places, they do send a ocular conjunctival swab pre-surgery. So, do you happen to do that in your practice, or is it anything?
In our practice, in our practice, we do not send a conjunctival swab, but it is definitely a good idea. What we really want to rule out in those cases is check the ocular adnexia, make sure that the sac is patent, there is no other associated ocular adnexial comorbidity, because that is going to increase the risk further. But yes, it is a good idea to send a conjunctival swab. We don't currently practice that.
Okay. And do you start patient on the pre-operative antibiotics or give intracameral antibiotics post-surgery for all the patients?
Yes, so that is a very important point that you mentioned, Dr. Sumit. So we ideally start the patients on topical moxifloxacin at least 3 days prior to surgery. Intraoperative, I mean, right before the surgery, you put in a drop of betadine, and then intracameral injection of moxifloxacin is very important, especially going under the IOL in the bag and giving a good wash of intracameral moxifloxacin has proven and has shown to have lesser instances of endophthalmitis by the Arvind Eye group studies and many more.
Okay, fine. Thank you. So starting a pre-operative broad spectrum topical antibiotic does help in reducing your
Antibiotics.
infection, and intracameral moxi does help in preventing the risk of endophthalmitis. So that is a very important take-home message. Uh, yeah, I think we have covered most of the questions. Fine, then we can take a leave. Dr. Nupur, thank you for your lecture and thank you for your time.
Thank you everyone for
Thank
your
you everyone.
patient
Thank you,
listening.
Dr.
Thank you.
Kumar Chugani and whole team of your medical college for joining in. We do have webinars like this every Tuesday and Thursday, 7 to 8 p.m. and they are mostly PG oriented. So we'll be happy to have you as audience, and you can suggest us if any other topics you want to be you want us to cover, that we will do it accordingly. So thank you everyone for your patient listening and having presence for the lecture. We will meet again on the Thursday. Thank you, Dr. Nupur. Good night.